respiratory system is divided into two tracts, the upper and the lower. The upper starts with the nose, moving down into the pharynx, moving into the larynx, then to the lower tract, which starts with the trachea, also known as the windpipe. It has C-shaped cartilaginous rings to provide structure but still allow food to pass. The trachea then branches off into right and left primary bronchi, which also have the C-shaped rings until they are in the lungs and the rings come together. Bronchi divide into bronchioles, up to 23 pairs, and resembles a tree. At the end of the bronchioles are alveoli and alveolar sacs, which is the primary site of gas exchange. Structures from bronchi all the way to alveolar sacs are encased in the lungs, which are then divided into lobes, the left having 2 to accommodate the heart, and the right having 3. All these structures are in the thoracic cavity.
Lung function is aided by various muscles, but most important is the diaphragm. When you breathe in, the diaphragm contracts, which increases the volume of the thoracic cavity and decreases the volume of the abdominal cavity. When the diaphragm relaxes, the volume of the chest cavity decreases and pressure inside increases, and air is pushed out of the lungs. The process of breathing is divided into two parts, inhalation and exhalation. Inhalation involves drawing air in. The diaphragm moves downward, allowing for the lungs to expand and fill with air. This causes the air pressure in the alveoli to become less than atmospheric pressure. Because the pressure within the alveoli is less, air is forced in by the higher atmospheric pressure on the outside of the body. Exhalation is when you breathe out, expelling carbon dioxide waste. The diaphragm relaxes and moves back up. The lungs contract, and the air pressure in the alveoli is now more than the pressure externally, which causes the air to be forced out of the lungs. Gas exchange is the delivery of oxygen from the lungs to the bloodstream and the elimination of carbon dioxide from the bloodstream to the lungs. It occurs in the lungs between the alveoli and the capillaries. A concentration gradient works on the exact same principle as a pressure gradient, allowing gases to flow from high to low concentration. Carbon dioxide is at a high concentration in the bloodstream, so it moves into the alveoli where the concentration is lower, and oxygen is at a high concentration in the alveoli, so it moves into the bloodstream where the concentration is lower.
So what happens when these structures get destroyed? What is pulmonary fibrosis?
Pulmonary fibrosis is categorized by chronic inflammation and a permanent process of fibrosis in the interstitium of the lungs and the alveolar walls. It is the progressive replacement of normal lung parenchyma with fibrotic tissue. It includes an anatomical distortion of the airways, seen with a first stage of alveolitis, destruction of the alveolar units, followed by fibrosis. Inflammation is a preceding characteristic. Many of the chemical mediators and cells included in inflammation are also contained in fibrosis. Fibrosis is essentially scar formation, or the abnormal collection of excess fibrous connective tissue, which leads to a thickening of the walls of the lungs and produces a reduced oxygen supply in the blood.
Now that we understand lung fibrosis, let's look at how it affects lung function. The activation of myofibroblast deposit and increased extracellular matrix leads to the destruction of normal alveolar structure, causing a disruption in critical gas exchange. Changes also alter cell behavior, and a positive feedback loop between fibroblasts and extracellular matrix promotes fibrosis. The progressive scarring of lung tissue and decrease in lung function is characterized by a restrictive volume pattern and reduced gas exchange capacity. The effects on the lungs lead to new or worsening dyspnea and increased oxygen requirements. This all then leads to a decrease in alveolar epithelial cell proliferation and secretion of profibrotic mediators. A necessary requirement for the formation of an effective gas exchange is the close proximity of capillaries and epithelium. Fibrotic areas have less blood vessels. The changes stated within the lungs then result in the reduction in the cross-sectional vascular area throughout the lungs. Changes within the pulmonary arteries of the lungs show a broad range of alterations, from isolated thickening of smooth muscle layers to complete occlusion of vessels by scar tissue and plexiform lesions.
The cause of IPF is unknown. However, there have been common factors found amongst people with IPF, such as genetics and family history, cigarette smoking, GERD, gender, age, and various environmental exposures. The belief is that more than one factor attributes to the development of IPF. The two main signs and symptoms of IPF are shortness of breath and chronic cough. Less common symptoms include chest pain or tightness, weight loss that's unexplainable, fatigue, loss of appetite, and finger clubbing.